I don't know if it's like the superhero persona or whatever, but I think that a lot of times we minimize. We use words like only and just. Well, it was only a little smack, and I don't even have a mark on me now to show it. And because of that, I always say you don't have to wind up in the trauma bay to make out this report. And if you don't make it out, then the people that can actually do something about it will never know what's happening.
Hey everyone, welcome to the Nursing Insights podcast. My name is Stephanie and I'm a registered nurse practicing in the state of New Jersey. Getting right to it, the state of healthcare right now is tough, to say the least. Let's just say that the nursing shortage does not spark joy. We can sit in that and stew in it for a while, but we can't live in it forever. Things are changing. So join me as your host as I partner with the New Jersey Collaborating Center for Nursing to hear from nurses across the state about their experiences, trials, and triumphs in the nursing profession. Welcome to the Nursing Insights podcast. Today, we have the pleasure of welcoming Kathleen McCarthy onto the podcast. Kathleen, welcome. Thank you so much for joining us.
Well, thank you for having me. It's really a great honor to be here and to talk about a really very important topic of workplace violence. Thank you for having me.
And Kathleen, we know that you are quite the specialist. You have a history in this space. Could you tell us a little bit about your background?
Well, I've been practicing nursing for half a century now, always in psychiatric mental health nursing. I have worked in a lot of different places as a staff nurse. Right now I work as a nursing educator here at Jersey Shore University Medical Center on the psychiatric mental health unit. I've worked at the visiting nurse, and I also have been educator and teacher for nursing students for a great many years. I'm a psychiatric mental health clinical nurse specialist, which I have been for all my nursing years, which is like an awful lot, over half a century.
And I was wondering if you wouldn't mind sharing some of the stories from your career about workplace violence that have really stuck out to you.
Well, I think the one that stuck out to me very personally, being a psychiatric mental health nurse, and during my career, I also worked for the Visiting Nurse Association for the service that was the psychiatric behavioral health unit. So we got to see the psychiatric patients. So they had just opened this branch of the visiting nurses because, as you know, a lot of times home care agencies are like less than thrilled at going to see a psychiatric patient, even if their need happens to be physical. So this was brand new. And one of the nurses that was hired at the time was a master prepared psychiatric mental health nurse, and her name was Marcia Granucci. And she was killed on a home visit. She didn't come home that night. Her husband was wondering where she was. They found that her car was still outside one of her visits. And what happened was she was visiting an elderly couple who was concerned about their son who had chronic mental illness. And so she was going there to speak with them about options that they had. Well, when she got there, he was there. He had already killed his parents. He shot her, and then he shot himself. So that was like such a terrible example of violence, workplace violence. And this was, again, looking back, this was a highly qualified mental health nurse who never had the chance to use it, because she was basically ambushed at the front door. That, I think, is what a lot of times what happens is that, like, once we have a terrible incident that occurs, then we look at, like, what could we do differently? So by the time I started, which was only a couple of years later, because The Visiting Nurse Association was so traumatized by that incident that they basically let the program they didn't do anything with it for several years until they felt that they could do it again more safely. And so now when somebody calls, they ask questions about like who's in the home and, are there any firearms? And there are certain neighborhoods that if you get a call in a certain neighborhood, you have to have security meet you and go out with you to that area. I mean, that was just a terrible example, and it affected me personally. But it wasn't until that happened that then, people look back and look at like some of the root causes and then see like what can be done to make the system safer. I think that safety is something that we really need to focus more on, to emphasize more as people are going through school. We're there to take care of people, but you also have to be aware of your own safety, your surroundings, who's around, who's behind you, who's in front of you. And I think that very often we just assume that, because we have this role, because we're nurses, that no harm is going to come to us. And I have to say, again, I told you I've been working for a very long time. Back when I was doing my education, getting my BSN and doing my public health component, it was in New York City. And I would wear the seersucker blue uniform and have my little black bag. And I would ride the subways and I would go into the projects. And very often, just somebody seeing that uniform would say, oh, can I help you? What place are you looking for? I'll walk with you to make sure you get the right place. So a while back, that actually was something that, being a nurse garnered a lot of respect from the general public. However, that's not the case anymore. We live in a very different society. Violence is kind of normalized in a way. And here we are in healthcare, and we're the face, if you will, for all the frustration that people have. I mean, look what happened in New York a couple of months ago to the United Healthcare executive. Most people don't even know his name, but the person who murdered him, he's been idolized. I think that's just a lot of the frustration that people have with healthcare has been coming out in waves, droves. And there was, as I say, people don't even know the name of the man who was murdered, but they do know the name of the murderer. He has his own little fan club, I guess,
I want to congratulate you on the publication of your article, The Impact of Patient Assaults and Aggressive Behaviors on Nursing Personnel's Stress, Well-Being, and Intention to Leave Post-COVID-19 Pandemic, that was published in the Journal of Nursing Administration. So congratulations on having that published. I'd love to hear a little bit about why you conducted this study.
Well, we were aware that the incidence of workplace violence has always been an issue in healthcare. People come in, they have a lot of stress, trauma. Obviously, something went wrong in their life or they never would wind up in the hospital. A lot of times when they come in, it's not even that they're doing it of their own free will. And who greets them? It's us. It's the healthcare people. And they have sometimes some very unrealistic expectations of what to expect in a hospital. Some of it is fueled by the media. I mean, I don't know if you've watched any of the Chicago Med or, any of the Grey's Anatomy. People come in, they get, sometimes the doctors are bringing them into the emergency room and they get rooms right away. And, they have chiefs of all the departments walking around. But the reality is that, when people come in, there are a lot of barriers. They need to be triaged before we can even recognize them in our computer system. And so we're the face of like the hospital, the administration, controls. If you're a behavioral health patient, you have to wear different clothing, so workplace violence has been an issue for a very long time. In fact, the American Nurses Association in 2015, they had that position paper on incivility, bullying, and violence for nurses and student nurses. But it seems like since COVID, the incidents were increasing, that the annoyance, anger of people who are coming in is greater. They had a lot of, I think just a whole lot of trauma, post-traumatic stress. I think COVID caused us a national PTSD that we really haven't appreciated. We've kind of forgotten how awful it was. And I think that as healthcare workers who were there experiencing that, they also had a PTSD, which what do? Well, we think that we're so super that we just kind of bury it and keep going on. We're healthcare people, and we care about the people that come to us. And when they have outcomes that aren't what we would expect, it affects us. And I think that we need to recognize that and encourage people to talk about it, to debrief each other when an incident happens. And very often we don't. We just shrug it off and go into the next room. But I do think that since COVID, a lot of the staff were experiencing that the aggressive, even assaultive behavior from patients as well as visitors was increasing, that people had much less patience and, were much quicker to get angry and demanding very quickly. So we were asked if we would like to join the study. Ohio State University was doing this research study about the increase of violence and aggressive behavior after COVID. And then they asked if it could be an interstate study. And they asked us, as the only New Jersey hospital, if we would like to join them. And of course, we jumped at the chance. And so it's 3 hospitals that were studied, 2 in Ohio and us here in New Jersey at Jersey Shore.
For a little bit of context for our listeners, could you actually also define for us what workplace violence is as we get into this study?
Well, workplace violence is actually any kind of an action or a threat of physical violence or harassment, intimidation, or any other threatening or disruptive behavior that takes place in the workplace. And it can be from patients, from visitors, or from other staff.
Looking at the study, what was your thought process behind how you approached the study, how you designed it, and then what were some of your results?
So, one of the things that we were looking at in the study was what instruments we were going to use and what we were going to study. We had heard these anecdotal stories. So the perception of prevalence of aggression scale, or POPAS, POPAS, that took a while to find an actual aggression scale. So this was one of the survey instruments that we used to actually measure the perception of aggression that the staff was feeling. And then a work stress scale was used. A work engagement scale was used, and health-related quality of life scale was used, and the final one that was used was intention to leave. And then we had some demographic information. So those were the instruments that we were using to assess the staff's perception and to ask them whether this behavior, occurred infrequently, very frequently, like a Likert scale of how often this behavior occurred. And so those were what the instruments that we used. So of the 3 hospitals, prior research had shown that behavioral health units and ED units experienced more aggression and violence than other units, but they hadn't really compared it with the medical surgical units. And I know from the classes that we were offering is that staff on the medical surgical units were also experiencing quite a bit of aggression and violence, including the labor and delivery units and the pediatric and the NICU units. So they had never really compared if there was any difference in terms of the different units. So the 3 hospitals invited the emergency department, the psychiatric mental health units, and 2 med-surg units that were comparable in all 3 locations for the staff on those units. And so we sent out 1,070 invitations, and 432 responses came back. And of those responses, 70% were RNs, PCAs were 21.5%, and EMTs were 8.5%. And they found that 44% of the staff from the med-surg units replied, 28% of the responses were from the behavioral health unit, and 21.9% of the responses were from the emergency department staff. Females far outnumbered males in the study, 76.6%. They also found that 38.6% had less than 5 years experience in healthcare, and that 57.9% were employed in their specialty less than 5 years. So I think that speaks to the turnover that we're experiencing in nursing, especially in these specialty units where having seasoned people with new people is a great help in keeping workplace violence to a minimum and learning de-escalation techniques as you go on the spot at the time. But a lot of our seasoned nurses have been going to other units that were less stressful to them. So I thought that was really eye-opening to see the number of relatively new nurses who were answering this questionnaire.
Yeah, those are really interesting results. I remember reading your article as it was given to me, and I'm a med-surg nurse, and I remember looking at those numbers and thinking, I remember all of the incidences that I had, and to think of how that could be reflected even more so in the behavioral health and the ED units is just, I believe it. I absolutely believe it. And I really think that there's something so personal for so many of us, when we review these studies and we look at these studies, because so many of us have our own stories, have so many of our loved ones and friends and colleagues who've also been, involved in workplace violence incidents. The experience as a nurse coming into the workforce and learning about the real kind of pervasiveness of workplace violence. I remember coming in as a new nurse, and my first exposure was the first day on the job when they sat us down, for brand new nurse training into the hospital and said, these are some of the things you need to watch out for. And I was actually singled out in my class, being of Asian heritage. They literally pointed at me and said, just a couple years ago, there was a girl who looked like you. We had a Vietnam veteran patient who had mental health, crisis behavior issues. And because he thought he was back in the war, he had flashbacks and he just launched himself at this young nurse. And that was it. She was unable to come back to work. She required many, many operations in order to undo the physical harm or to address the physical harm that happened to her. And I remember being there as a brand new, fresh out of school nurse thinking, oh my God, is this going to happen to me? And thankfully that had never happened to me. But of course, everybody I know, the nurses that I interact with, my friends, my colleagues, each had our own incidences in which we were afraid of being followed out to our car. We've been alone in a room with a patient and had something said or something, proposed to us. the incidence is overwhelming. And I think a big part of that, which you were alluding to, is, it's so pervasive. And at the same time, people sometimes struggle with reporting. People struggle with speaking up or talking about what happened or what could have happened. Do you think that there's any recommendations you have for what could be done in that degree, in that realm?
Yes. One of the things that I learned from teaching this class in crisis intervention and de-escalation is that some of the areas that you wouldn't even think about, the nurses have experienced episodes of violence. We had one nurse who worked in the PICU who said that she was slammed against a wall by a father who I guess had some court order, or he wasn't able to visit his child, or there was some issues with him being there. And of course, his anger was at the person who was right in front of him, giving him that limit, and he just slammed her up against the wall. So in the class that I give, I always talk about doing what we have here is the one link, or it's like an incident report. It's a very comprehensive system, very easy to use, has a lot of different tabs, and a special one for workplace violence. So I always ask people if they've used them and encourage people to use them. And so what I say to them is the bar for reporting an incident, because this is not a part of your job, the bar is very low. The bar is, did you ask for it? And if the answer is no, I did not ask to be called a name or pushed or pulled or threatened, I did not ask for it, well, then make out the workplace violence incident report. So one time I had one of the PCTs that we have, she raised her hand and she said, well, the other day somebody threw a garbage can at me, because a lot of our observers and PCTs do the one-to-ones. And of course, who needs a one-to-one is your most patient who needs the most observation, who oftentimes is the most disturbed. So should I have filled it out because it missed me? So because she didn't get hit, she was thinking that like she was okay. I said, well, just because you duck, the person is not a good pitcher. Yes, you did not ask to have a garbage can thrown at you. And I think that sometimes people don't make them out because we have a tendency, I don't know if it's like the superhero persona or whatever, but I think that a lot of times we minimize. We use words like only and just. Well, it was only a little smack, and I don't even have a mark on me now to show it. And because of that, I always say you don't have to wind up in the trauma bay to make out this report. And if you don't make it out, then the people that can actually do something about it will never know what's happening. You're on the front line. This is just data. The more data we put in, the more chance there is for the administrative people to see if there's a pattern. I do tell the story that on our unit, on our psychiatric mental health unit, a few years back, we had a lot of issues around visiting hour. Now, we only had, unlike the rest of the hospital that right now has unlimited visiting hours, we had 1 hour. And it's, fairly well defined. 2 people, visitors can't bring things into the patients. But we found that a lot of times we had issues like during visiting hours, when people were trying to pass things to the patients, afterwards, patients seeming like they had some like altered mental status. And so we started making out one links, which is the incident report, about these situations that were occurring during visiting. And we actually were able to have a security guard that was assigned to the unit specifically during visiting hours. So, I do give examples in the class to say that, like, it does work. It might not work immediately, but you have to keep putting in the information, real-time information, so that people can see, like, is this happening during mealtime? Is it change of shift time? Is there a special shift? Is it a day of the week? All of these things can be looked at, but without data, we really can't make any kind of change. And I think that on the other hand, as far as leaders go, that when somebody does make out the incident report, I think that leadership needs to get back to the person to make a connection. Because here's the other thing. It's going into like a black hole, like no one's going to read it. Well, if administration lets the person know, I read that and that concerns me, what happened to you. I mean, I think that's another way of encouraging people and letting them know that it is read. And so the nurse who works with me, Julia, she actually has a personal story that she wrote one weekend. We had a very disruptive woman on the unit, and she had been assaulted by this woman like 2 or 3 times quickly, and she wrote out 3 different reports. And the next morning, the director of nursing called her on the unit to ask her, "Are you okay?" Like, that's amazing. And I think that needs to be done consistently. And I think the other thing is that instead of just focusing on like the incident that happened, it's kind of like my Marcia Granucci story. We need to look at the root cause. What is it about the emergency department that as soon as people come in there, they get even more stressed because it's so crowded? And whatever they come in with, we have our own triage system. So what I think is like a grave emergency, the triage person is giving it like a 3 or a 4, like it's very, very low compared to what comes into the hospital. So I think that like the encouraging people to make them out and to have the leadership let people know that these are read and that they're taken seriously and that we're making efforts to listen to what you're asking for and to do them. So here in our hospital, I know you said about people, when you were on your med surg floor, about patients or visitors being able to follow you. So nurses were very concerned that when they were wearing their name, first of all, they didn't want to wear their name tags. And the reason was because when you put your whole name on, it's very easy for people to find you. And so we did have some stories of nurses who said that like former patients or their relatives showed up like in their neighborhood. Very frightening. So we did a pilot study, and now throughout the system, the only thing on your name badge is just your first name and last initial. So that has gone now through the whole system. But unless nurses started reporting that or requesting that kind of a change, I don't think anyone in administration would even have thought of like, should we change the name badge on people? And they have. The other thing that they've started doing is securing all the entrances much more securely so that visitors have to get a pass and have to show like a identification before they come in. And the other thing is in the emergency department, they now have been wanded for weapons. So all of these improvements have come because people have asked for them. So I think it's really important for leadership to keep on reminding people, tell us, because once we know, then we can do something about it. And even though it doesn't happen immediately, things move slowly in a big institution, but they do change. So I think that will help people to fill out those incident reports and not to minimize them. And the other thing is, I think that it's important that people realize what they should report. And it doesn't have to be any like major life-threatening illness. Like I say, the bar is very low. If you didn't ask for it, then make out the incident report.
I just love that reflection of how the whole system can come together and change in order to make the workplace safer for our staff, for our nurses. I think the element that you've been talking about, how minimized it is, how normalized it is, a big part of having the leaders come down and say, yes, I see you and I recognize this as a problem, is a big part of pulling out that normalization and saying, no, this is not normal. This is a conversation. This is something that needs to change.
Mm-hmm.
I have been a med-surg nurse. At this exact moment, I happened to be working a corporate role. And I remember having the conversation where somebody had come in and was yelling, and I went to one of my coworkers and we had a conversation about it. And I said, well, at least nobody threw an IV pole at me. And everyone stopped and turned and looked at me. And I was like, oh, I'm the only nurse here. And everyone's like, is that what happens? And I said, actually, yes, sometimes. And that's not what we want to talk about. But again, coming from like the nursing floor into a corporate setting, everyone's like, that's absurd. But on the floor, it's, oh, that just happens. And it's just not a normal thing. And it's not something that should be happening to our staff and to our nurses. So absolutely. I love the message of having leadership come and support the nurses who do report. One of my favorite nursing professors in school would always say, if we want best practices, if we want, evidence-based practice, we need data. And if we need data, that means we need to get it from somewhere. And if we want those practices, if we want things to change, we have to be part of that data collection. We have to be part of the generation of a case that says we need to make something change for this. So absolutely. It's really the onus is on everybody,
Yes.
and to encourage each other so that things like this don't happen again.
Yes, yes. So I think that another thing that leadership needs to keep in mind is that sometimes staff feel that there's some conflicting values, that we have all these patient satisfaction scores. So I think it's like really important that administration, that the providers, that everybody get on board with this zero tolerance for violence. Yes, we do want patient satisfaction scores to be high, but we also need to let people know that while you're frustrated, it is not okay to take it out, your anger or your frustration on the staff here. So the other thing that I also emphasize in my classes is, and I'm speaking as a very senior nurse, is that when something happens, sometimes younger staff have gotten the message that it's part of the job, and no sharing of war stories of like, oh, you should have seen what happened to me when I got whatever it is. That really gives a very poor message to the younger staff, who then will incorporate that idea that like, oh, well, this is just part of the job. It isn't part of the job. It's kind of like people who work in retail. I guess shoplifting is something that they look out for, but they never would think that that's normal behavior. I mean, if they find one of their customers is shoplifting, it's like, you cannot do that, and there are repercussions. Well, being aggressive and assaultive to healthcare people is not part of the job. It's like, no, you may be frustrated, you may be angry, but this is not the way to deal with it. So I ask them, if I said to you, and so I'm going to use you, Stephanie. I'm going to say, Stephanie, what if I said to you, Stephanie, I'm really so sorry that I called you a dumb little nurse before. I didn't mean it. What should you say? And so then instead of putting you on the spot, I ask the audience, so what should she say? And I've been very impressed that lately the newer staff members say things like, thank you for your apology. Yes. Because some of the more seasoned people, when I have let them answer it, they would say, oh, that's all right, I understand. It's like, no. So not to put anyone on the spot, I asked the rest of the people, what should you say? And so the answer is, you say, thank you for your apology, but it's very hard to help you. what I'm trying to help you when you are calling me names. So what could you do differently in the future? And I also say, so if I go to ShopRite and I'm getting the message, well, that's okay. I can call anybody that I want dumb. And I say to somebody, oh, you dumb person, I was here first. I could wind up in trauma. So it's not even helpful to the patients to give them that idea that that's okay. It's like the rules of society that operate outside of the door of the hospital operate inside. This is not the Wild West when you come in here, that it's lawless. No. And so if you do that on the outside, you'd have serious repercussions. So what could you do different in the future? So that's like part of the ongoing message all the time is like, the bar is very low. Did you ask for it? And then when someone does apologize, because very often when people are coming down after they've had like an incident, a crisis situation where they have kind of lost control, either verbally or physically, they do get to a state where they have attention reduction and they're embarrassed or they're remorseful or they're crying or they're just more relaxed, and they oftentimes apologize. And this is like the perfect time to let people know, I accept your apology, but this is not okay. And next time, what could you do different?
And talking about severe repercussions, I think that's a wonderful segue into talking about the New Jersey Healthcare Heroes Act. In 2023, Governor Phil Murphy did sign the Healthcare Heroes Violence Prevention Act, the Healthcare Heroes Act, which included posting signs with the following: it is a crime to assault a healthcare professional, any volunteer working for a healthcare professional or working at a healthcare facility, or any employee of a healthcare professional or healthcare facility while they are performing official duties. So anyone who assaults a healthcare professional or any of those named folks is in violation of the prohibition will be subject to a fine, imprisonment, or both. I would love to know any of your thoughts, Kathleen, about the Healthcare Heroes Act.
Well, I think it's wonderful. And I also, when I encourage people to make out the incident reports, I also remind them that the government is thinking that, like, we need to be protected and we should take it seriously. And so, of course, you wouldn't be filing a complaint against somebody, who was a 100-year-old delirious lady who thought you were, trying to kill her and she was trying to protect her life, or a 5-year-old who's kicking your leg, constantly. However, if you believe that someone has deliberately tried to harm you, you need to let security know so that they can fill out a report. Several years ago, this is before the Healthcare Heroes Act, one of our security guards had said that there was a patient who, whenever he came into the hospital, either in the emergency department or up on the med-surg unit, was very destructive. Either like targeting, physically targeting staff, and very destructive to the environment. Like when he got upstairs, he would be like jumping over the nurse's station and pulling out monitors and just very, very angry and destructive. So this security officer had gone to court because this patient, his case was in front of a judge, and the judge said, I see this complaint. Are there any others? Do you have a history of complaint? And the answer was no. There was only one complaint that was filed against this person who did this constantly. So again, his story is another example of there were consequences for these behaviors. So up on our unit, maybe about a year ago or so, we had a patient I have to say that on the psych unit, most of our incidents are verbal. We do have some physical, and many times the staff gets injured almost like as a byproduct when somebody is like trying to get out or things like that. Usually not deliberately aimed at a person. But we did have one night a patient who had like a history of being in prison. And he came up So the male nurse was sitting in the day area. It was in the middle of the night, and he was talking to some of our aides. The patient came up behind him, and he had worked on taking the sheet and just braiding it in a very thin rope, like a rope, and came up behind him and went like right in back of him. Now, luckily, he had been to the class, and one of the class moves is like, what do you do if somebody tries to choke you? Well, the first thing is you put your shoulders up, to protect your airway. And the second one is to relieve pressure. So that's what he did. He put up his shoulders and pulled down on this lasso. And then other people came, and thank goodness the nurse lived. But obviously now he was somebody that had charges filed against him. I hate to talk about just the extremes, but I think that those are the kind of things that you remember. And so, yes, I do encourage people, that if everyone else is caring about us, we need to also take care of ourselves. I've been looking at some of the workplace violence incidents here in our facility, and our numbers are going up. And one of the things that the director of security had said to me is, I don't know if the numbers are actually increasing or if the staff is actually reporting more. And I'm hoping that it's that people are actually reporting more, with the idea that, again, data, unless you have it, then nothing can change.
Those are amazing, amazing movements that you're making in your workplace in order to make the staff and to make the experience of working in healthcare so much safer and so much better for all of us. So thank you so much, Kathleen. We have a question that we like to ask all the nurses who come on our podcast, which I think is really pertinent considering how stressful the area of workplace violence is. We like to ask the nurses who come on the podcast, what do they do? What do you do, Kathleen, to take care of yourself after a long day of working as a nurse?
Oh, well, I'm so glad you asked that, because that's another thing that I talk about is like how important it is for us who are givers. And you can't keep giving all the time unless you replenish. Like, what do you do to replenish and take care of yourself? So what do I do? If the weather is fairly nice, I like to go down by the boardwalk. And, this happens more in the spring, not when we've had the single-digit numbers. But I work here at Jersey Shore. We live quite next to the shore. And so it's just a short drive from the hospital down to a local little beach. And sometimes just taking a little, 15, 20-minute walk. Sometimes at certain seasons, there are foxes that actually have their little pups there. It's just so interesting. I like reading and, of course, talking to my friends and, just kind of debriefing, talking about things other than work and being involved with my family, because I have grandchildren. I even have some great-grandchildren now. So that's very interesting. And the other thing is, I have to say that I start every morning by meditating, taking some quiet time for meditating and prayer. I find that like a spiritual connection is like really so important, because I think that's also then goes out into the work that I do with patients. So that's what I do to replenish. And again, encourage people. It's different for everybody. We're so good at teaching others what to do. If we only practice what we preached, we'd be so healthy. It would be so amazing, but we don't always. So.
Thank you so much, Kathleen. Thank you for sharing your insight. Thank you for working hard on behalf of all the nurses who've been under your care and for all of the nurses who are in the workforce now. Thank you so much for taking this time to speak with us, and we thank you for being on the podcast.
Well, thank you for having me. This was really quite a nice experience. Thank you, Stephanie.
Thanks for listening, everyone. We'll see you next time on the Nursing Insights podcast.